Well, good morning, everybody. Welcome to Palliative Care and Geriatrics Grand Rounds. I'm here at Camden. I have the pleasure of introducing our speaker today, Dr. Kate Brizzi. So Kate went to medical school at the University of Pennsylvania. She then went on to complete a neurology residency here at Partners. She then went on to do a specialized fellowship in neurology. I just want to make sure I get this right. The Advanced General and Autoimmune Neurology, which just sounds like a fellowship only for really, really smart people, which is true with Kate. We were lucky in that she then went on to do a fellowship with us here in the Harvard Combined Palliative Care Fellowship, both at Mass General, Dana-Farber, and Brigham and Women's. And then she actually stayed on faculty at Mass General with a dual appointed role with the Department of Neurology, as well as palliative care, where she serves as an integrative palliative care clinician in the ALS clinic, which is what she's going to be talking about today. And Kate's interests are really at the intersection of neurology and palliative care, as you can see, and in particular about how do we optimize training for our folks interested in this area, as well as enhancing provider communication skills. So with that, welcome, Kate.
Thank you so much for the introduction. It's great to be here. Just gonna get settled here. I was very excited to be here and talking with all of you today. I was thinking about sort of what would be the most helpful thing to tell you about ALS for a palliative care audience. When I was reflecting, I realized that a lot of the patients that palliative care specialists end up seeing from an ALS perspective are often in the inpatient setting. It's often patients who've gotten admitted after maybe an aspiration pneumonia, or admitted in the context of a procedure, or these other sort of decision points that come up in the course of illness. And, I was reflecting that it's really a challenging place to be for a palliative care provider, especially not having had a longitudinal relationship with that particular patient, trying to understand where that patient is within the context of their illness, to be able to have and engage with them in a conversation about kind of their goals and values and thinking about medical decision making. So what I'd really like to focus on today is give you a little bit of a framework for sort of thinking about ALS. And then specifically, I'd like to go through some of the different types of treatments that we have available for ALS, and talk a little bit about some of the evidence that's behind it, so that you can kind of come to those types of consultations sort of armed with knowledge about what is actually the data behind some of these procedures that we discuss with our patient population. And then I'll end today talking a little bit about what I've sort of learned about some of the differences between the ALS population and the oncology population that we're used to seeing, and briefly tell you a little bit about what we're doing in the ALS clinic here. I have no financial disclosures. So again, for our objectives today, we'll talk about illness trajectories in ALS. We'll talk about the evidence surrounding different treatments, and then I'll talk about the similarities and differences between palliative care and ALS and oncology. So just to start off today, I would like to talk about a case that I took care of relatively recently. So this was a gentleman. He is 33 years old. And he had been, about a year ago, had developed significant respiratory compromise, as well as weakness in his extremities. Really, though, the respiratory onset was first. And he was ultimately diagnosed with ALS, and it was an incredibly challenging diagnosis for him and his family. He's now progressed somewhat. He requires wearing BiPAP 24 hours a day. He has two children. He has a 1.5-year-old and a child that's going to be 4. And his wife is really providing the care for all of them, for both the children and for him, sort of 24/7. And it is a daunting, daunting task. And so they came into the clinic because, he had expressed early on in his illness that he really couldn't imagine living in sort of a dependent state. In particular, the idea of sort of a trach and a ventilator was something that he really did not want. But he was coming in because he said that, his thinking had evolved on this, and he was worried. He was finding that his illness was progressing and he wanted more time with his children. And so he was trying to grapple with these different things that were going through his head. He was worried about how that type of a decision might impact his family, what would be the impact for his wife. And so we were having a conversation around all of these issues, and it's really challenging. It is really challenging for these patients and their families being in that position. So let's talk a little bit about ALS. When we think about ALS, we often think of motor neuron disease and ALS as sort of synonymous. ALS is a type of motor neuron disease, so there are other types of motor neuron disease. Other types include hereditary spastic paraparesis, spinobulbar muscular atrophy, infectious causes of motor neuron disease. So for example, polio or West Nile can actually cause a motor neuron disease like ALS. And then spinal muscular atrophy, which some of you may be familiar, especially from the pediatric perspective, as there's been some recent treatments from that standpoint. It's the numbers that I saw quoted. This is actually, these are papers from Laura Foster, who was a fellow here last year. She wrote a review. Was that the prevalence of it is 2 in 100,000. I think, you know, I was sort of surprised actually to see that number, because I think maybe being at Mass General or a place like this, it feels like it's a more common illness. The cause is really unknown. There's a lot of hypotheses about what could be potentially contributing to it. There's thoughts that potentially it could be a dysregulation of sort of microRNA and problems with building proteins. Or potentially could it be that there are changes in ion channels that lead to excitotoxicity affecting the motor neuron? We don't really know. These are different hypotheses that are being explored from a research perspective. The typical onset is quoted as being in the 7th decade of life. I will say anecdotally, just being in the ALS clinic, I feel like it's younger. You know, overall, it seems like most of the patients I'm seeing are generally in their 50s and 60s, with patients, as I mentioned, that can be as young. I've actually seen some patients in their 20s and patients up into their 90s. So this really can span any time where patients can develop this illness. I do want to just note offhand, there's often a lot in the news about head trauma and ALS. This has been an area that there's been a lot of research that's been going on. As of now, when we've sort of looked at more rigorous studies looking at matched controls for patients that had head trauma and ALS, it doesn't look like there is a definitive correlation. So I think that's an area that there'll be still ongoing research, but as of right now, it's not definitely clear that there's a correlation between those two. So ALS is a very heterogeneous disease, and just to review our neuroanatomy, it affects both upper motor neuron and lower motor neuron nerves. So what does that mean? So your lower motor neuron nerves, that's nerves that basically leave the spinal cord and go out to your extremities. Your upper motor neuron nerves, those are nerves that are in the central nervous system, so they're in the brain and in the spinal cord. And ALS has the ability to affect both, but it can do so in different ratios. And that can change how the disease presents. For some patients, they'll have a predominantly sort of upper motor neuron pattern, meaning that, again, the nerves in the brain and the spinal cord are most affected. We actually give that a different name. It's called PLS, or primary lateral sclerosis. I bring this up because it does have implications for prognosis. So patients with PLS, the primary lateral sclerosis, median prognosis in those patients is 8 to 10 years. Whereas for sort of more typical ALS, as we think about it, we're thinking about 2 to 4 years. The thing that's tricky there is that patients with PLS can convert to having ALS anywhere along their path. So someone may have PLS for years and all of a sudden they have sort of a rapid decline. They redo the EMG and they see that actually there's now lower motor neuron involvement and it looks actually more like an ALS picture. So it makes it really challenging to prognosticate in these cases. Most patients present with what we call limb onset disease, meaning that they develop weakness in a distal extremity. So typically, so for example, in the hands, in the feet, foot drop, hand weakness. There are about 20% of patients who will develop what we call bulbar-onset disease, and that means that they'll develop dysphagia, which means difficulty swallowing, or dysarthria, so difficulty speaking, so affecting really kind of the mouth region first. And then a very small percentage are going to present with respiratory onset. That's actually quite rare. In the patient that I mentioned to you, that's actually a relatively rare presentation of ALS. The ALS can affect muscles throughout the entire body. And really when we think about this, the presentation is typically one of painless, progressive weakness without sensory changes. This is important because, you know, patients will often have come in and will be worried about the possibility of ALS, but really this disease usually does not present with pain as an initial feature. There's There are some exceptions to this rule, certainly, but overall, it's painless progressive weakness. Usually it's in the distal extremities as opposed to the proximal extremities. So usually we're thinking about hand or foot weakness as opposed to hip flexor or shoulder weakness. And then difficulty swallowing and speaking, and eventually it will affect the muscles that affect the ability to breathe. I think that aspect of ALS, the sort of fact that it affects all muscle types, makes it a particularly challenging condition. The other thing that's important to know about ALS is that it can have effects on cognition. And I think we're really only beginning to understand how profound this might be. Recent studies have estimated that up to 50% of patients that have ALS may have cognitive changes. Now, that does not mean necessarily that they meet criteria for dementia, but that they may have cognitive changes. There is an association between ALS and frontotemporal dementia. This is often has a genetic basis, and I'll talk about that in a minute or two. However, we don't really know how many patients that have ALS and actually have FTD. The estimates on how many of these patients there may be really varies. I've seen numbers quoted in the literature ranging anywhere from sort of 10 to 30%. So there's really a wide array. But it's important to recognize that this exists because it may affect patients' ability to have a conversation about sort of their goals and values, particularly later in their disease. And so recognizing that this is a possibility, I think provides an impetus for sort of earlier conversations with patients as well. We know that the severity of the cognitive changes that patients may experience does not necessarily correlate with their quality of life, based on some studies that have been done. But we do know that cognitive changes are a predictor of caregiver burden. And so that's another reason why I think this is an important thing to be looking into. So how do we actually look for sort of the cognitive changes in this patient population? I want to highlight this today because I think most of us are most familiar with sort of the mini mental state or the MoCA test for looking at cognition. We actually have a different test that we use in ALS. And so if you're seeing this in the chart, I just want to highlight sort of what this means. We use the ALS cognitive behavioral screen for this patient population. It looks at a couple of different areas. So they look at attention. So they look at patients' abilities to follow commands. So for example, they'll ask the patient, can you point to the ceiling after you point to the door? Multi-step command. They'll ask them to do things like mental addition, like how many syllables, what are the number of syllables in this word? And then they'll do things with eye movements, which I think is interesting. They'll look at saccades. So they'll have patients kind of look at a finger that's moving and have them say, I want you to look at this finger and then switch back and look at the other finger that's moving. And then they'll do anti-saccades. So they'll actually ask them, look at the finger that's not moving. So they have to be able to kind of shift their attention to this new task. And then they do tests of concentration, so asking patients to repeat numbers, and then tests of tracking and monitoring. And those are, for example, things we're familiar with, like asking the months of the year backward, or they'll ask them to do attention to alternating numbers and letters, like A, 1, A, 2, B, 3, C, which is actually quite challenging once you get going. And then they'll do initiation and retrieval task, asking patients how many F words can you generate in a minute. And then based on this, they can generate a score, and it's out of 20. And so patients who have a score of 10 or less, that's thought to be 100% sensitive for frontotemporal dementia. There is a second page to this where they actually ask the caregivers about their experience from a behavioral perspective of taking care of the patients. Patients that score low on that, there's about an 86% sensitivity for frontotemporal dementia with those changes. With this first page, they say that if patients score a 17 or less, that it's suggestive of some cognitive impairment. And I think you can take that all sort of with a grain of salt depending on the patient that you're working with. There are some patients who have an inherited form of the disease, and I think this is particularly important to know as palliative care providers because we may be interacting with family members as well. So there are about 10% of patients with ALS will have a familial form of the disease, and the other 90% are thought to be sporadic. Within the familial category, there's about 2 or 3 genes that make up the majority, with the largest being this C9orf72, it's right here, that makes up about 40% of the familial cases. Those cases also have a higher correlation with frontotemporal dementia, and so there's often an association that is seen there. We generally recommend genetic testing in patients who have a young onset of the disease. So if they are, and they categorize that as less than 50 years of age, that they should have genetic testing, or patients that have a family history of either FTD or ALS. And I would say there's some variability in that because sometimes we don't know it's actually FTD. So if there's a family history that seems like a family history of dementia, especially dementia that seems like it was at a younger age, that will often trigger sort of the discussion about genetic testing. I've seen in our clinic, oftentimes we'll work together sort of with genetic counselors in thinking about this discussion because it can have huge implications for family members as well. I now want to kind of move to talking a little bit about some of the symptomatic treatments that exist in ALS. I'll talk a little bit about some of the interventions that I think you're used to hearing about, so PEG or gastrostomy or non-invasive ventilation. I'm not going to talk in detail today about actually medications for the physical and emotional symptoms. It's too broad of a topic, and I think that could be a talk in and of itself. We'll talk a little bit about some of the ALS-specific medications, and I hope to give you a little bit of a background of thinking about those medicines and where they may, where the limitations of those medications might be. And then we'll talk a little bit about some other aspects of care, including multidisciplinary care. I think one of the things that we all think about when we think about ALS is the implications it might have for patients' ability to swallow and to breathe. I think that's often something that is on the providers' minds, it's on families' minds. And so there's oftentimes during the course of the illness, there will be questions that will arise about nutrition. And conversations about a feeding tube almost inevitably occur. We have a lot of conflicting data about this right now. And I would say that right now we have no randomized control data that is proving the superiority of a gastrostomy tube to during oral feeding with blended foods. There's no randomized control trials looking at that. There are, however, multiple other studies that have looked more at sort of prospective or retrospective data that have shown that there may potentially be a survival benefit. That being said, there's also a number of large studies. There's one of at least 300 some patients that did not see any survival benefit. So I think we have a little bit of conflicting data and more is sort of needed to know about this. We do know, however, that weight loss does correlate with progression of disease and with reduced survival. So that is one thing we do know. We do know also that PEG tubes overall have a relatively low complication rate. So it's actually only about 2% of patients have complications related to the PEG tube. I think there's still these open questions about potentially a sort of survival benefit and also questions about quality of life. There's conflicting data looking at this as well, with some studies suggesting that improvement in quality of life and others suggesting that there's no change. Generally, we think about having conversations with patients about a feeding tube if they're having trouble swallowing, if they're having weight loss, and ideally if their breathing is above what we call a 50% on the SVC. So that's a test that basically looks at their vital capacity. And so if they have evidence that they have a stronger vital capacity, it would be a better time to do the procedure just because it's a bit safer to do it when they're able to breathe more easily. That's not a hard and fast rule, but that's sort of how we think about it, at least in the clinic. When we think about patients making decisions about feeding tubes and non-invasive ventilations, it's a complex decision for many reasons. There was a study that was done that looked at about 21 patients, and they interviewed patients who had made a recent decision about feeding tubes, and about 16 of them had decided to have the intervention. And so they asked the patients, they said, well, what were the factors that kind of went into your decision? And they fell basically in 3 categories. And the first was sort of patient-centered factors, and that included patients' perception of control over their illness, as well as fear That also played into the sort of patient-centered decisions around it. The second category that factored into decision-making were external factors. So how their providers presented the material, what their family members thought about the procedure. And then the third category, in terms of the themes that came up when they're in their interviews with patients, the third was a concept of time. And that fell in a couple of different ways. It could be patients' concept that, they needed to do this, that time was short for doing this procedure, that they needed to do it soon, versus patients' perception that this would give them more time. So I think there's a number of different sort of themes that arise when patients think about making these types of decisions. When I sort of think about it, we certainly present the pros and the cons of decisions like this with patients. Overall, it is relatively safe. As I mentioned, the complication rate is only around 2%. It does appear that a feeding tube does help to maintain weight. And as I mentioned before, it does look like maintaining weight may have some survival benefit. We haven't had a study to actually look and see if then by transitive property, those things are true. But it does help certainly maintain weight. And then it can certainly be helpful for patients who have a lot of worry about eating. I have a number of patients that I've seen in clinic who tell me that they spend all day just they're so fatigued from trying to swallow and eat things very slowly and soft things that it is a chore to have to go through and eat. And they really worry about choking. They worry about factors that go along with eating. And so they look at the feeding tube as a tool to potentially help alleviate that worry. I think the downsides are there are potentially complications. I said the complication rate is low, but it's not zero. So certainly these feeding tubes can get clogged. They can get infected. And then there can be complications around the time of placement of the feeding tube, particularly for patients that have impaired respiratory status. There is a feeding schedule that typically comes along with a feeding tube. For patients who are using it for nutrition, they typically have to adhere to a relatively strict feeding schedule. And then I think the last, piece that is, not to be underestimated is the psychological impact of a feeding tube. I've had a number of patients who say to me, I think I would want this at some point, but I'm worried because it feels like this means I'm moving on to a new stage of my disease. It's like it feels like an acknowledgement of a change in disease. And in some ways they may be right, that it is a new phase, a different phase of the disease. And I think that can be particularly difficult for patients and their family members. Similar to decisions about feeding, another thing that comes up is decisions about breathing needs. And this was I'm just going to highlight this here. This was a landmark study that was published in 1999 looking at BiPAP for patients with ALS. And basically what they saw was that BiPAP did improve survival and the rate of pulmonary function decline in patients with ALS. They basically looked at patients in 3 different groups. So they looked at patients who used BiPAP for more than 4 hours a day. They looked at patients who used BiPAP but for less than 4 hours a day. And then they looked at patients, that's the group 3, that did not use the BiPAP. And what they basically saw was that in the group that used the BiPAP for more than 4 hours per day, at 18 months, their survival was 21%. Compared to those who use it for less than 4 hours per day, their survival was 5%. So 21 versus 5% was a pretty significant difference. And then survival was 2% in the group that had refused BiPAP altogether. They also saw that basically the group that used the BiPAP the most actually had a slower decline in their vital capacity. In general, they saw the greatest benefit for this for patients who had bulbar-onset ALS. So again, the ALS that affects sort of the mouth and throat region. So based on this study, the authors of this study recommended initiation of BiPAP or conversation about BiPAP if the forced vital capacity, the SVC, the slow vital capacity, is less than 50%, if they're having dyspnea, or if there's a rapid change in their ability for breathing. And based on this study, actually a lot of sort of insurance guidelines have sort of come into play. And so oftentimes insurance companies may not approve BiPAP for patients who don't have an SVC that is less than 50%. And so there is some other metrics that can be used. But some of these studies have then translated into sort of insurance type of guidelines. What we do see is that, in addition, non-invasive ventilation may improve certain quality of life metrics as well. We in the clinic, we often recommend this as part of our treatment for fatigue. So for a lot of patients, especially just getting started on non-invasive ventilation, they can't handle being on it for the whole night or for a prolonged period of time. And so some patients, when they're first getting used to using it, will use it after they've been fatigued for some reason as a way of kind of getting a catch-up. And they'll use it for a little while until they feel better, they'll take it off. And then they may eventually use it more and more. We do also see that there may be correlations between use of the non-invasive ventilation and improvements on the SF-36, particularly in the vitality category. And it looks like it may lead to some improved ratings and quality of life, although again, similar to as we were talking about with PEG, for every study that shows one thing, there's a study that shows another. And so it's very, very challenging. I will say, though, that overall, my sense of things from just being in the clinic is that most of the patients seem to take a lot of benefit from non-invasive ventilation. The patients who find that they don't like it are typically folks who have a lot of secretions, and they find it hard to actually have the mask on. Those patients may not like using the non-invasive ventilation, and then some patients just don't like the way the mask fits. Though I've been impressed by how many different types of masks there actually are, and there's a lot of ways to kind of work with that if a patient says that the main reason they don't want to use it is because of a mask. So overall, I think we tend to sort of recommend this as an intervention, at least in this particular clinic for patients who meet these metrics. I'm going to just say a word about mechanical ventilation. So this is a very complicated decision to pursue mechanical ventilation. It is overall in the United States fairly rare. So just to give you a sense, the number that's quoted in the literature that I had seen was about 10%. Though I actually, in talking with my colleagues here, the number that I hear them quote to patients is around 7%. And actually, it's probably even lower here at our institution. In the time that I've been here over the last year, I've seen maybe I can probably say a handful, of patients who have considered undergoing trach and vent. It is overall a fairly rare thing. We see it much more commonly on the inpatient setting often. I think that comes up more often because these are patients who are really sick and are admitted to the hospital, and they're at a sort of transition point in their illness where those conversations come up more frequently. I think it's really interesting that the frequency of mechanical ventilation is very different based on where you are. So in Japan, up to 23% of patients actually undergo trach and vent compared to the United States. So they looked at this actually and they said, well, what are the sort of factors that contribute to this difference? And there were a number of things that came up. One was that in the United States, it seemed like there was more emphasis on the patient's perspective on maintaining quality of life, whereas in Japan, the most common theme that came up was about sort of reaching a milestone when they had interviewed sort of patients and family members. They also noticed that caregivers in Japan were more in favor of trach and vent as opposed to in the United States, and so that may have some influence. And the way that providers talked about it was also very different between in the hospitals in Japan versus in the United States. I will also note anecdotally that, and I don't know if this is in fact true, but I've heard that in Japan actually it's also paid for. So that the care for mechanical ventilation is completely covered by the government, which I wonder also how that may influence that decision as well. In talking with the patients and families, this is really, we think about it as and I've heard the providers use this is a game changer. We think about this in a very different sort of way than we think about decisions about PEG, decisions about non-invasive ventilation, because this is a decision that really doesn't affect just the patient, it ends up affecting the entire family. So patients who do choose to undergo mechanical trach and mechanical ventilation, they're going to really require 24/7 care. And most rehab facilities require that at least 2 people are trained in the use of the trach and vent before they can actually be discharged from the rehab facility. There are huge financial implications for this, and most patients are not able to get sort of full coverage for the care that they need, and it often requires nursing level care for the trach and vent as opposed to using PCAs. So there's a lot of other sort of factors that go into this decision. And I was in the meeting the other day with this patient that I was talking about at the beginning. One of the providers that's been there for a while, she was kind of educating the patient about this, and she was saying to them, I think about this, that this needs the same level of consideration as, as a couple thinking about having a child. Because this is something that in some ways, this is gonna be a long-term decision that really may change and affect everyone that's involved. That being said, there are many different reasons why patients may choose to undergo this procedure. Patients' goals, may have implications here. I think especially I see it often discussed more in terms of with some of our younger patients may talk about trach and vent more often than some of our older patients, particularly those that have young children. I think that the decision can also be affected by sort of the way that the information is presented. I've had some patients who have thought that maybe this was going to be very similar to the non-invasive ventilation that they already experienced, and they don't realize that some of the other factors that go into it, and then the cost and care considerations that go into this as well. Given that this is a palliative care audience, I just want to make a word about multidisciplinary care. So one of the exciting sort of benefits of multidisciplinary care that we see actually in ALS is that it actually improves outcomes for these patients. So survival, they looked at patients in Ireland who either got multidisciplinary care versus seeing a general neurologist. And they, what they saw was that patients who went to the multidisciplinary clinic, their survival was 7.5 months longer than patients who had gone to just the general neurologist. And the 1-year mortality was actually reduced in the patients who went to the multidisciplinary team as well. They found that especially patients with bulbar-onset ALS were especially helped by this. And I wonder if part of that was sort of the access to the rest of the team, including the speech and language pathologist, et cetera. And so as a result of this, this is actually now for the most part, this is sort of the consensus sort of standard of care is the really multidisciplinary care for ALS. These studies, palliative care was not part of the team when they did these studies. And so that is a newer feature of the multidisciplinary teams that are kind of cropping up around different places around the country. I now want to talk a little bit about some of the medication treatments that you may come across and that conversations may happen in the inpatient setting about whether or not to kind of continue or discontinue these medications. The first one I want to talk about is Riluzole. So Riluzole was approved in 1995. It was the first sort of FDA-approved treatment for ALS. It is an oral twice-a-day medication, and what it does is it inhibits glutamate release, which then inactivates sodium channels. Overall, a fairly well-tolerated medication, though it can cause some upset stomach and some hepatotoxicity as sort of the main potential sort of side effects. And so this study, which was in the New England Journal, was a randomized controlled trial looking at Riluzole in ALS. And basically what they saw was that in about 55 out of 77 patients who got Riluzole were alive at 1 year versus 45 out of 78 who did not get Riluzole. When they looked at this data in a little more detail, they saw that the effect was actually greatest for those with the bulbar onset disease. That's the middle sort of graph there, where they saw the most survival benefit. I will note that when they went back later and looked at this data and they made adjustments for patients' age, for their duration that they had the illness, what they saw was actually that the survival benefit was really at 1 year, and that if they looked out at 21 months, they didn't see the survival benefit anymore. So that's important just to know, is that, it looks like maybe there might be some benefit for this sort of early on, but that benefit does not then translate into longer term. I've heard my colleagues in the ALS clinic, the way they talk about this with patients is that it may provide a 10% slowing of the disease for some time. That's the number. I have to ask them actually where they come up with a 10% number because I'm not entirely sure where that comes from. But that is the number that I've heard them sort of quote to patients. I think it's also important to know that these studies that were done, they were looking really at survival. They did look at patient-reported functional outcomes as well, and they didn't see any benefit for the patients that were on Riluzole for patient-reported functional outcomes. So that is one of our treatments. And then most recently, I don't know if many of you have heard of Edaravone, if that's come up yet. So this was actually a new treatment that was approved in 2017 by the FDA. And it was based on these landmark trials out of a group in Japan. So Edaravone is a free radical scavenger. It is administered via an IV. and we'll talk a little bit more about how it's administered. In the trial that looked at edaravone, they had about 200 some patients in a double-blind placebo-controlled trial. And what they saw initially when they did that big group was they saw a trend toward benefit, but it wasn't actually significant. And so what they did was they then went back and they analyzed the data more, and they looked at the subgroups. And they saw that actually patients who had mild to moderate swallowing difficulties, so not the severely affected patients, the more mildly or moderately affected patients, that they actually had a significant slowing in their scores on the ALS-FRS. So the ALS-FRS is like a metric that's used to grade patients' sort of functional ability. And what they saw was that patients, they still had a decline, but they declined by 5 points on the scale instead of 7.5 points on the scale. That's actually not a dramatic difference, but it is a significant difference based on the study that they looked at. And so, based on this, looking at this trial, it seemed like the people who were, benefiting from this the most were the people who were more mildly affected. Patients who had a relatively recent onset of their disease were included in this trial. So it was patients who had onset of their disease within the last 2 years. The patients who were included in this trial also had little respiratory involvement overall, and overall less disability than what we think about in terms of the sort of broader ALS population. This is important, and I highlight this because the FDA, there was a lot of excitement about this medication. It was the first medication in a lot of years that was for treatment of ALS, and so it was actually approved for all ALS by the FDA. But insurance companies, because of the data where this has come from, oftentimes have looked at this and said, well, the patients who actually benefited were these certain subset of patients. And so it's been really challenging for our patient population because some of them have been very excited about getting this potential treatment, and then only to find out that the insurance companies will not necessarily cover it because they do not meet that sort of metric. I do think it's really important to educate patients on sort of where the data is coming from, for this particular treatment, just because, again, there are certain limitations to what it actually can provide. Just a few facts about it. So it overall appears fairly safe. It's an IV infusion. It's given for 10 days every month, and sort of indefinitely. It's very expensive. So it's $11,000 per infusion cycle. So that comes out to about $146,000 per year. So if it's not covered by insurance, most families cannot afford this. And then it needs to be administered via a PIC or a port. So there's other sort of access considerations that go into play. There are, I think, a lot of things we don't know about edaravone. I think the effects on respiratory function are not really fully understood. Again, those patients weren't really included in the initial trial, and so we don't really know about those effects. The trial wasn't really looking at survival, and so we don't have a good sense of the effects of edaravone on survival. And then, for folks that are outside of the study population window, we don't really know the effects of this particular medication. So I think it is exciting to have a new potential treatment, and hopefully maybe this will be an avenue that others can think about from a research angle. But I think that we still need to know a little bit more about, what it does sort of long term. There are a number of other potential therapies that are on the horizon that I just want to speak about briefly, because these may come up in questions from patients. I do think it's actually an exciting time in general for the field of ALS, and that there's a lot of research that's happening, and there is a lot of hope that there's going to be some breakthroughs that are going to be coming in the future. I think in particular when we think about the genetic aspects of ALS, so there's been some research looking at gene silencing techniques, specifically for patients that had those mutations I mentioned before, the C9orf72 or SOD1 mutations. And then there's also a lot of research into stem cell therapies. Right now, though, neither of these therapies are certainly approved or have shown have proven efficacy. I do want to say a word about stem cell therapies because I think this comes up often. Questions from patients. Right now, the ability that we have, the stem cell therapies are not going to basically be able to replace the motor neuron itself. So motor neurons that have already degenerated, the stem cell therapies can't replace those. It does look like it's actually safe to administer stem cells. That's basically where we are with the trials that have been put out to date. Those trials were all looking at sort of safety and route of administration. We have not done any placebo-controlled trials looking at stem cell therapies at this point. And so none of the trials that are out there have been powered to measure efficacy. And I think this is really important. It's tough, I think, that, in terms of for patients trying to get their information from different places, and it can be at times look like stem cell therapies may be further along than they actually are. It is very exciting that these are in clinical trials and that, they're making steps along the research pathway. But right now, none of these trials have been powered to measure efficacy. So we've been focusing a lot on treatments that tend to affect patients' sort of physical ability. But I think it's really important to note that quality of life is really not always correlated with patients' physical function. This is a really nice paper by Zachary Simmons on this. And basically they talked with a number of patients, and what they found is that the patients who tended to rate their quality of life highest were patients who were able to experience a frame shift, that they were able to move from emphasizing their sort of physical abilities to more thinking about existential interpersonal factors. I think this is actually a really important point, because as we think about our treatments and our strategies for working with this patient population, we have to think outside of just the physical treatments alone. So what can actually affect quality of life? We see that psychosocial factors may actually be some of the best predictors of ratings of quality of life. Depression is not correlated with physical impairment, but what we do see is that social support and coping strategies really can be correlated with how patients will rate quality of life and whether or not they will be experiencing significant depression. So I want to talk a little bit about some of the unique aspects of palliative care in the ALS population. And these are mostly sort of my observations, having come from doing the fellowship and seeing a lot of patients with oncology conditions, and now thinking a little bit about what is unique about this patient population. I'm not going to dwell on the first point, the lack of effective treatments, because I think we've talked a little bit about what the treatments are that we have available and their limitations. I do want to talk a little bit about some of the communication limitations that come up in ALS, because I do think that this is something that is unique in comparison to the heart failure population or the oncology population. These patients may experience a very early onset of difficulty with communication. And there are routes around this. There are ways that we can help to augment their communication, but it really does make it challenging in certain instances, because what I've noticed is that, it's sometimes hard for these patients to get their voice heard. Because it may take them longer to type. It may take them longer to speak, to be able to make their voice known. And so oftentimes it feels like the surrogate decision maker is acting and is kind of being their voice. And so we have to pay a special attention to making sure that we're hearing the patient's voice. I think it's also an impetus for having earlier conversations about patients' goals and values, because while they're able to communicate fully, in some ways, and at least from my perspective, that is a time to really be able to flesh out some of the things that are important to them. There are a number of augmentative communication devices that can help maintain the patient's voice. And so making patients aware of this and getting this involved early can be very helpful. Patients can do a voice banking or message banking. There are a number of equipment strategies. And actually, I put Boston Children's Hospital up here because that's actually where we send a lot of our patients for augmentative communication. Anything ranging from sort of boards that they can use to kind of give messages to sort of laser eye pointers where they can type out. So there's a number of different ways that patients can continue to communicate with us. I do want to just make a small note there that I think they're often perceived that ALS does not affect eye movement. And while it's true that that's one of the last things that's affected, what we see is for patients who've been on a trach or ventilator for many, many years. So we're talking patients who've been on it for 10 years or so. What I've observed is actually that they do have reduced eye movement abilities. And so unfortunately, it means at some point in the disease continues to progress despite the mechanical ventilation. And so at some point, patients will lose that ability to communicate as well via their eye movements. There's a profound loss of identity that I think occurs in ALS that also, to me, feels different than what I see in the oncology population. Patients report a number of different things. They did a study that looked at basically ALS, they looked at COPD, they looked at end-stage renal disease, and they looked at elderly that were very frail. And they looked at sort of how they rated their experience in a number of ways. And patients with ALS were more likely to rate that it was more problematic for them to being able to kind of carry out their routine, that they had more worries about the future, they had more sensation of a loss of role, more of a loss of personhood, and more of a loss of control and privacy than patients in those other populations. This is pretty profound for the patients that I see, and it's one of the things that I think makes this disease most challenging, especially if there's a shift in roles where someone has previously been the provider for their family and now is shifting roles where someone else is kind of fulfilling that role and taking care of them. It can be incredibly difficult. Another thing that I think is unique about this patient population is that I've gotten a number of questions about physician aid in dying. It's not to say that I never heard this in other patient populations, but I hear it much more often from patients with ALS. They've done a couple studies to look at what were predictions for patients to make a request for hastened death. And things that seem to correlate with that include depression and anxiety, loneliness, perception of being a burden, and a low rating of quality of life. I've noticed that patients will often bring this up very early in the disease. So this is not necessarily something that they talk about as once they've had the disease for years on end. This is something that often comes up in that like first or second visit where they've gotten the diagnosis, and that this is a question that comes up. One thing that I think is really important about this is that I see this actually as a bit of an opportunity to really have a conversation with the patients about the future, about their worries about the future, a conversation about what they're perceiving, what the future might be like. I think there's a knee-jerk reaction to kind of answer this from a legal perspective, and I guess I would encourage folks to kind of lean in a little bit and find out what is actually behind that ask, because oftentimes what I've found is that a lot of it is patients just not knowing. They're just worrying about what the end of life might look like and not knowing what that is. And for a number of patients, once I've talked with them a little bit about what hospice is, about how we sort of treat symptoms, that it helps to allay a lot of the anxiety around this. And so I look at this as sort of an opportunity it's a conversation opener as opposed to something that people should sort of shy away from or be afraid of. The next thing I just want to touch on is the caregiver needs. This is huge. I cannot emphasize this enough. I have been astounded by what these caregivers are able to give of themselves for these patients, for their loved ones. It is a huge ask for these caregivers. I saw it quoted that it's estimated that caregivers spend about 11 hours per day with a patient on average, and that's people who may have paid help as well. And a lot of times these people are also juggling their own jobs, they're juggling children. It is really difficult. And the patient that I mentioned at the beginning, it was really interesting being in the room because his wife was able to express just her own worries about, she's like, I just don't know how I'm gonna hold all of this together. She's like, it's just me. She's like, I don't have any other additional help, and I'm not sure, if he ends up going through with this procedure, how we're really gonna be able to handle this. And so opening up sort of that dialogue, because I think that's a really important piece. Caregiver burden is rated higher than for caregivers of patients with Parkinson's disease, of cancer, and of dementia. And we see that there is more caregiver burnout or burden in patients who have more cognitive and behavioral changes. When they've looked at sort of markers for caregiver distress, they see that generally it doesn't actually correlate as well with the patient-specific factors. So for example, the ALS-FRS, that sort of metric that we look at for how patients are functioning, that doesn't always tend to correlate very well with the level of caregiver distress. What we actually see in predicting who is at a high burden state versus a low burden state is more so other factors, so anxiety, depression, how caregivers rated their quality of life. That was much more predictive of those that were going to be at a higher burden versus a lower burden. This is something I'm particularly interested in, and if anybody else is also interested in this, I'd love to talk about this some more, because I've been trying to think about what strategies and ways we can help to support our caregivers. A lot of these folks, they can't really give up the time to go to support group meetings or to kind of leave. They're coming from far away. And so I've been trying to think about ways that we can think creatively about helping to support them. As I mentioned, sort of rates, the rates of depression in caregivers really can vary and can be quite high. I saw it all over the map, anywhere from 10 to 61%. But what I thought was actually, this paper in particular noted that I thought was really important was they said, well, you know, rates of DSM-rated depression aside, what they actually see is that distress is high, and that is actually really important. And they had a number of really poignant quotes in this article. For example, you know, patients saying, or caregivers saying things like, "I don't have my life anymore," or "This is the toughest thing in my life." Or quotes like, "To see him deteriorate is terrible." And so they said, you know, a lot of these caregivers that they interviewed were actually quite resilient and maybe didn't meet metrics for depression, but they met high levels of distress and really do need supported. And then the last thing I just want to mention is factors in hospice decisions. That's, I think, a little bit different. You know, I think for these patients, there is certainly that balance, again, between the hope for a cure and the reality of their disease. And we're at a place where there is a lot of hope that there'll be breakthroughs in the coming years, but we don't know how soon that's going to be or when that's going to be. And I think for patients, that's a particularly difficult factor. I think a lot of the patients like to be involved in research as well, and I think that also influences decision. And one thing that I've been kind of just learning a little bit about is the sort of cost factor of some of the equipment that patients need. So I realize that this may vary from hospice to hospice, but in general, it's challenging for patients to get the power wheelchairs or some of the augmentative communication devices after they're on hospice. And so trying to get all of those things up front. The augmentative communication devices, just to give you an idea, I looked those up. So the one with the sort of board that they can kind of touch, that's anywhere from $5,000 to $15,000. So they're really expensive. I don't know the details of that. Yeah, I assume it is, and I think that's why people actually want to do it before they end up going on hospice. But yeah, really, really difficult. The ALS network is a very robust network between different people that have had the disease and different organizations. And a lot of patients are actually also able to get loaner equipment available as well. And so I encourage patients to be plugged into the various organizations that are in their area, because it may help them to get additional resources. And so lastly, in just our last few minutes, just to tell you a little bit about what we're doing here. So we have a multidisciplinary team in the ALS clinic that is comprised of a number of different people. There's the ALS physician. I really should have redone this sort of model. They're kind of a little bit I would say they're kind of like the quarterback and get the different people involved. There is the ALS nurse. There's a physical therapist. There's a speech and language therapist. We have a chaplain and a resource specialist, and then I'm one of the newer members to the team as the palliative care specialist. And the way our clinic typically works is that the multidisciplinary team works gets together in the morning and determines who each patient needs to see on the team. These are long visits. The patients come in and they're often here for 3 or 4 hours at a time, and so it can be very fatiguing for patients, but at the same time, the overall sense I've gotten from patients is that they prefer that to coming back for multiple visits to see different providers. We've been experimenting with different sort of triggers for who to see. They see an average of about 35 patients in the ALS clinic per Tuesday. And so I can't see them all. And so we've been experimenting with figuring out who are the best people to get palliative care involved with. We don't have good data on this. And so this is, I think, an area for research and thinking about, really what should be the triggers for a palliative care specialist as opposed to kind of doing primary palliative care for these patients. In general, these are what we've sort of come up with. So patients with sort of rapidly progressive disease, and that's based on the physician's sort of assessment. those with psychosocial complexity or high levels of caregiver distress, those with frontotemporal dementia concurrently. Patient request, the good word about palliative care is getting out there. I've had a number of patients that have actually asked for palliative care, which is pretty cool. And then patients who are at transition points in care. So I often see people who are thinking about a PEG tube, and that's been an opportunity for a discussion about broader goals. There are benefits and limitations to doing it that way, and I'm happy to talk about that more at some other time. I think we're going to continue to explore different modes of care delivery. So experimenting with televisits as another opportunity for reaching out to these patients when it's difficult for them to come into clinic. Looking at sort of routine versus trigger-based visits. Should we be seeing patients sort of throughout the course of their illness? And then looking at what outcomes we should be assessing, as well as sort of documentation practices. How can we make sure there are a lot of conversations that are happening behind the scenes about patients' goals? How can we make sure that those are documented and so that everybody in the team knows what the patient's wishes might be? I'm thankful for the support of the neurology and the palliative care teams, and I will happily take any questions. Thank you so much for your attention.
That was really wonderful. I don't see these patients as much as maybe some of the other populations, so I oftentimes feel a little bit ill-equipped and because of all the complexity that you laid out in their care. Yeah. So there was a lot of really practical stuff that I feel a bit more empowered about. Great. So thank you. Questions from the audience for Kate? Yep. Eric? We probably have time, I think, maybe for 2 questions.
Thanks, Kate. The reason that Dr. Kamdar maybe hasn't seen a lot of patients is because we don't get the referrals. This has been, for me, having been here a long time, an interesting transition because in early years, Merit Sutkowitz would send, we always had at least 1 and often 2 or 3 patients we were following with ALS, but you guys do the job yourselves now. So I think that's one of the places where palliative care has been able to infect our our colleagues. Just one other comment. The government of the Russian Federation, which is a country of 150 million people, has decided that long-term ventilatory support now will fall under palliative care. So there are hospices now gearing up to have vent units, and ALS, when the neurologists, at some point there's a shift in care from neurology to palliative care, and palliative care is the main provider for people with advanced ALS. So it seems like exactly how to take care of these patients is different in different places. The question that I have is there a routine in your clinic about goals of care discussion, and in particular, whether or not people want to be on a ventilator and get trached and G-tubed, and when does that happen, and how do you decide whether the patient is ready to hear it, or do you always do it? Do you insist on it? How do you decide about that? Thanks.
So what I've observed is that there's upfront, at least early on when patients are diagnosed with the disease, there's a discussion about the trajectory of the illness and just sort of the discussion about what to anticipate, maybe conversation topics ahead. I think it really varies by provider in terms of how often those areas are re-explored. I think there's different factors that play into that. I have noticed that the decision around the PEG tube often is when the trach and vent conversation comes back again. It's usually discussed in the context of patient's going to have to undergo anesthesia. There is a potential that it may be difficult to extubate them, and so that is sort of when that discussion happens. I think there are pros and cons to that. In some ways, I feel like it doesn't feel out of place to the patient, I think, in some ways, to be talking about it then. At the same time, it can end up getting kind of muddled in the sort of medical piece and be a little bit more feel a little bit more divorced from overarching goals, depending on how that conversation is broached. And so that's one time where that is a sort of a definite sort of hard stop, where that is always sort of discussed at that point. As to whether or not it's done at other routine sort of times, I think that's very provider dependent.
So I'm just mindful of the time. I just wanted to check first before we wrap up to see if anybody from the Dana-Farber or any of the satellite locations had any questions for Kate. And then for folks in this room, if you have questions for Kate, maybe you can take them up at the front.
And I'm always happy, always feel free to email me or anything as well.
Okay, great. Thank you, Kate. This is really wonderful.